front of the screen to give you a view. So they will say hi.
Okay. So looking at the screen.
Are you ready, Dr. Ahmad? Can we start?
Yeah, we can.
So, good afternoon, everyone. Welcome to the seminar series of the College of Dental Medicine, which is accredited by the CPD department. And special thanks to Dr. Ahmad Al-Maaita, our speaker today, who accepted our invitation. Dr. Al-Maaita is a consultant orthodontist at Hamad Medical Corporation and Associate Professor of Orthodontics at Jordan University of Sciences and Technology. His area of interest are demineralization and white spot lesions, upper airway dimensional changes with treatment, cephalometric studies, temporary Anchorage devices, tooth color, accelerated tooth movement, and orthodontic wires. Dr. Al-Maaita has more than 20 publications in well-known peer-reviewed journals. He has supervised more than 20 master theses at JUST. Also, he acts as a reviewer for several orthodontic journals. Dr. Al-Maaita was an examiner in Jordanian Medical Council and internal examiner for master students at Jordan University of Sciences and Technology. Welcome again, and I pass the microphone to you, Dr. Ahmad, please.
Thank you very much, Dr. Aidan, for the nice introduction, and thank you for the audience for coming today. Today we are going to talk about the temporary anchorage devices uses in orthodontics, and we are going to cover anchorage, types of temporary anchorage devices, characteristics, advantages, disadvantages, and then we will talk more about microscrews, the insertion sites, the insertion techniques, and what factors affect the success rate of microscrews. We will talk also about the immediate versus delayed loading. We also will talk about the complications and limitations of the microscrews, and finally we'll talk about one of our studies which was carried out in Jordan University of Science and Technology, talking about alveolar bone density changes around microscrews. Then finally we'll show some clinical cases. So let's start with the anchorage. Anchorage can be defined as resistance to unwanted tooth movement. This is based on Newton's third law of motion, and I'm sure you're all familiar with Newton's third law of motion, which states that for each action there's an equal but opposite reaction. This applies in orthodontics actually, in which actions mean wanted tooth movement, whereas the reaction is the unwanted tooth movement. Ortify define the sorry, it's moving. Why it's not responding? Okay, so Ortify defined the anchorage as the base against which orthodontic force or the reaction of the orthodontic force is applied. So in this diagram, as you can see, if we extracted the upper first premolar, our wanted orthodontic tooth movement is to move the canine and the anterior teeth back distally into the extraction space. I can't hear point. So here the wanted tooth movement is distal movement of the canine into the extraction space, and of course the incisors to reduce, for example, increased overjet or to align crowded incisors. But the unwanted tooth movement, we don't want the posterior segment to move back. So we need to hold the posterior segment through anchorage reinforcement. So from where we can get anchorage? We can get anchorage from extraoral sources and from intraoral sources. I'm sure you're all familiar with the extraoral sources, including the headgears. Headgear for class 2, for example, and headgear for class 3, which is called reversible headgear. In the class 2 type, the headgear is used to hold the posterior segment, the maxillary molar teeth, in their position while you are retracting or moving the upper anteriors back. In the reversible headgear type, you are holding the upper anterior teeth while you are protracting the upper posterior teeth forward. Remember, with the headgear, the main disadvantage is the patient compliance. If the patient not comply with the headgear, if the patient didn't wear the headgear, you will end up with anchorage loss, definitely. And also, there is a very popular case report which was published by Booth, Mason, and Burney in 1988 about the eye damage, ocular damage by the outer bow of the headgear. Although later on, some safety measures were introduced to the headgear, like the nighttime lock, the caterpillar effect of the elastic chains applied to the headgear, but still the main problem is the patient compliance. Intraorally, we can get anchorage from the teeth through the root surface area, also from the bone, and this is the concept of Ricketts utility arch, where they move the root of the posterior teeth buccally into the bone to stabilize them and prevent them from moving forward. Also from the soft tissue and from the intraoral devices like transpalatal arch, lower lingual holding arch, and Nance appliance. And also, of course, from the fixed appliance mechanics, for example, using high friction mechanics compared to low friction mechanics, using push mechanics compared to pull mechanics. But remember, all of them do not prevent tooth movement 100%. So you will have some anchorage loss by using these devices. So in this situation, temporary anchorage devices can be a good choice for stationary anchorage or for absolute anchorage, although it's not 100%, again, not 100% absolute anchorage, but they prevent the unwanted tooth movement in a good way. By what? By using the temporary anchorage devices, there will be no unwanted, no undesired forces on the teeth, and most of the reactionary forces will be transmitted to the bone to which the temporary anchorage devices attached and fixed temporarily. So let's start with the definition of temporary anchorage devices. These are biocompatible devices fixed temporarily to the bone for the purpose of moving teeth, with the devices being subsequently removed after treatment. You can remove them anytime during the treatment. That's why they are called temporary. You can insert them easily and remove them anytime during the treatment when you finish your desired treatment plan. So they can be located also transosteally, subperiosteally, or endosteally. They can be fixed to the bone either mechanically through cortical stabilization or biochemically through osseointegration, which is the concept of the conventional dental implant. So general term skeletal anchorage, which includes the temporary anchorage devices, also can include the dental implant. Sometimes the patient comes to you with a dental implant placed already. Although this is not the common scenario, we usually advise our patient to have the orthodontic treatment done, finish, the spaces arranged, and then to place the dental implant, not vice versa. But sometimes the patient comes to you with the dental implant in. So what can you do? You can use the dental implant as a source of skeletal anchorage and plan your treatment around the dental implant. Ankylosis. Also, if the patient comes with ankylosed tooth, it's common for the upper first molar to be ankylosed, for example, or second primary molar. It's common for those teeth to be ankylosed, so you can use these ankylosed teeth as source of skeletal anchorage. And of course, the temporary anchorage devices, which includes the midparticle implant, implants, zygomatic wire, miniplates, and of course the mini screws. So let's start with the first one, the midparticle implant, which was first described and introduced by Weherbin et al. In 1996 through introduction of the ortho system, which is a palatal implant placed in the midline of the palate and connected to the teeth through transpalatal arch. Why midpalatal area? Because it's been suggested that midpalatal area is suitable for placement of a short implant. It has good quality bone and also it's away from the roots of the upper incisors. So, midpalatal implant consists of three parts. The first part is the endosseous body, which is around 3.3 millimeter in diameter and 4 or 6 millimeter in length. The transmucosal smooth neck, again 4.1 millimeter in diameter, 2.5 or 4.5 millimeter in length, and the head, which is the head abutment for the intraoral attachment, the part you see intraorally. Why midpalatal implant? Again, because it provides true osseointegration, similar to the conventional implant. The palatal vault, as I said before, provide good bone volume and it's away from the roots. However, they are expensive, and for the insertion and removal, they require surgery. You need to do surgery. During removal, sometimes you need also to take some bone with it. And of course, because it is a surgical procedure, you need a surgical guide, a surgical stent. This was explained nicely in a paper by Tosan et al. In 2002. And for the osseointegration, you need a latency period of around 12 weeks or so. The intraoral device can be complicated actually, because any change in the dimension through the impression or fabrication of the appliance, any change, small change of the dimension can result that the device will not fit nicely to the implant. That's why sometimes the technicians make the transpalatal arch with more flexible wire. So the clinician can adjust the wire if the dimensional accuracy is affected. Although this is advantage for the adjustment, but it can be also disadvantage because flexible wire can result in some sort of movement of the teeth and so anchorage loss. Clinically, there was a nice randomized clinical trial which was done by Benson et al. In 2007, in which they compared the clinical effectiveness of the midpalatal implant versus the headgear. They found that there was no significant differences actually between the tooth movement between midpalatal implant and headgears in terms of tooth movement or anchorage loss. That's why they suggested that midpalatal implants are useful tool for anchorage reinforcement. But keep in mind that this paper talking about patients with good level of cooperation. If the patient are cooperative, then the headgear will work. If the patient are not cooperative, then the headgear will not work, and so you can't compare it with midpalatal implant. So in their study, they reported that the level of cooperation of their patient was high. The second type is miniplates, which is also called a skeletal anchorage system. These are temporary anchorage devices utilizing titanium miniplates and monocortical screws fixed temporarily to the bone in the maxilla or the mandible to provide absolute anchorage. The idea of these miniplates actually came from the plates of orthodontic surgery. They use plate and screw to fix the bone cut in orthodontic surgery. So the idea came from that. Again, the miniplates consist of three parts. The head, which is this part you see intraorally. It's here. Okay, so this is the head. It's exposed intraorally and has three continuous hooks. Why three? To provide three levels of vertical attachment. Arm, this one, which is transmucosal, and it's available in three different lengths. It can be short, can be medium and long, and of course the body that's fixed to the bone by a screw. It comes in three different configurations. It can be T-plate, can be Y-plate, and can be I-plate. So miniplates, they fit very well for cases of intrusion and distalization of maxillary mandibular molars. Also for cases that describe as surgical cases. Sometimes by using miniplates you can convert the case from surgical case that needs orthodontic surgery to an orthodontic case without surgery. Also can convert an extraction case into a non-extraction case by allowing the orthodontist to move the whole segment of the teeth. Zygomatic wire, which was described first by Milson in 1998, They used 12-inch stainless steel ligature wire, which was placed and ligated to the body of zygoma. They reported case report on 10 patients who required retraction and intrusion of upper maxillary teeth, but unfortunately they had no posterior teeth to use for Anchorage reinforcement. They used zygomatic wire and they reported that it was successful. Now let's talk about mini screw and or micro screws, and I believe now every orthodontic clinic has micro screws in it, and most of the orthodontists are familiar how to use micro screws. There was a survey in 2008. They found that 80% of the respondents to a questionnaire said that they had at least one case involving mini screw in their practice. Why they are so popular? Because they are acceptable to the patient compared to headgear. They can be inserted easily. They eliminate the risk of ocular damage, as we mentioned before, with the headgear. The insertion and removal relatively easier compared to midparticle implant. The post-operative discomfort is very minimal. They are temporary. You can insert them and you can remove them anytime during the treatment. They can be placed buccally and palatally, and relatively they are cheap and proven clinically. Also, they are available for orthoforce application sooner after insertion, so you can load them immediately after insertion, although some researchers suggested to wait for 2 or 3 weeks after insertion, but many still load them immediately after insertion. And of course, they are available for variety of means and direction of force application. However, still there is a potential of root damage. While you are inserting your micro screws, you can hit the root. So you need to be careful while you are inserting your micro screws. Also, there is risk of infection, soft tissue irritation at or near the site of placement. Also, it's been reported for the premature loosening and failure, periscrew inflammation and screw mobility. These are the disadvantages of micro screws. These micro screws can be made either of titanium alloy or stainless steel alloy. Stainless steel usually is used for the thicker cortical plate and denser bone because they can resist fracture better than titanium alloy. The dimension, they came in the micro screws available in different dimensions, length and diameter. The diameter can be either 1 millimeter to 2.3 millimeter. They suggested that the thinner micro screws are easier to be placed between the roots. But although this is advantage, the disadvantage, the thinner micro screws are more prone to fracture compared to wider micro screws. The head type can come in different variety, can be bracket shape, can be round shape, button shape, small head, large head, short, long, and different means and types. You can insert your micro screws in the palate, in the palatal aspect of the maxillary alveolar process. Also in the maxilla, you can place them buccally on the buccal cortical plate, below nasal spine. In the mandible, you can insert them in the retromolar area, in the mandibular symphysis, and of course in the buccal cortical plate. While inserting your micro screw, you need to take care of these anatomical landmarks. You need to look at the soft tissue anatomy. You need to look at the interradicular distance, so you need to be away from the roots, not to hit them. You need to look at the sinus morphology in the maxilla, nerve location, especially mental nerve in the mandible, buccolingual bone depth. According to the buccolingual bone depth, you can choose the length of your micro screw, buccal and lingual cortical bone thickness also. The space between second premolar and first molar is the most common space to be used in the maxilla, whereas in the mandible, the space between first and second molar is the most common place for inserting the micro screw. There are two techniques for insertion of the micro screws. It can be inserted by self-drilling technique or self-tapping technique. The main difference between those two techniques are the preparation of pilot hole. In the self-drilling, there's no need to prepare pilot hole before insertion of the micro screws, whereas in the self-tapping technique, you need to prepare a pilot hole. It has to be thinner than the screw itself, so you can achieve primary stability after insertion. Kim and Coy in 2001 reported that self-tapping method has higher failure rate than self-drilling. In another study, they reported that after soft tissue incision, the self-drilling technique was more stable than the self-tapping technique, and also they concluded that pilot drilling showed less mobility and more bone-to-metal contact compared to menisco inserted by self-tapping technique. So those people are pro with the self-drilling technique in terms of better primary stability after insertion. Better primary stability, less mobility, so less failure rate. However, there was another study in 2012 which was a clinical study to compare between self-tapping technique and self-drilling technique, in which they recruited 20 patients requiring retraction of maxillary teeth. They placed the screw between second premolar and first molar at the mucogingival junction. They used the split mouth design. In one side, they used self-tapping technique, and on the other side, they used self-drilling technique. They apply their forces immediately after the insertion with a force level of 150 to 200 grams. And they consider that any sign of mobility and or inflammation would be considered as failure. They reported a high success rate relatively, which was around 78%, and they found no difference between those two techniques in terms of failure rate. And the major cause for the failure was the screw mobility. So if we are going to compare between self-tapping and self-drilling, do we need pilot hole for self-tapping? Yes, it is necessary. It is not necessary for the self-drilling unless the cortical bone thickness is high. It's higher than 1 millimeter. In this case, there's a risk of a fracture for the microscope, so it's preferable to prepare pilot hole and use self-tapping technique. The observation of the direction while insertion. In the self-tapping, it's easy because the screw will follow the path of the pilot hole. You already create a path for them and then they will follow it. Whereas in the self-drilling technique, it's difficult. You need to use your tactile sensation while you are inserting the microscope because the screw will create their own path. Widening of the hole entrance, it's possible with the self-tapping, with self-drilling, sorry, but it's not possible with self-tapping, again, because of the pilot hole. The pilot hole is already prepared and you insert the screw in the pilot hole. Primary stability, it is present in the self-tapping technique, but it depends on the dimension of the pilot hole compared to the screw. Screw has to be larger than the pilot hole, whereas in the self-drilling, usually the primary stability is better. Danger of fracture, it's low in the self-tapping because of the pilot hole, and there is a risk of fracture when using self-drilling technique. Time of insertion, it is low relatively for both techniques, but I would say it's lower in the self-drilling than self-tapping because here they compared the insertion itself, but they didn't count the time needed to prepare the pilot hole. From A to Z, it will need longer time. So what are systems available in the market? We have many systems in the market. So let's start with the MTech mini implant system from 3M. This is self-tapping screw. It comes with different length and diameter, and it comes with different head shape, hole in the head for variety of attachment. Spider screw Anchorage system, it can be either self-tapping or self-drilling. Again, it comes with variety of dimensions, and the head comes with variety of shapes. The aarhus Anchorage system, which was developed by Milson in 2005, it is self-drilling. Apsu Anchor micro-implant system, this is self-drilling screw, and the head shape can be small head, no head, circular head, bracket head. So where to insert your microscope? Actually, the insert point depends on the movement you are planning to achieve. So the screw can be situated either above or below the mucogingival line according to the movement you need. If you need distalization only, then you need to insert your microscope below the mucogingival junction. If you need distalization with intrusion, then you need to insert your microscope above the mucogingival junction. So look, for example, at this picture D. They inserted the microscope here above the mucogingival junction. Look at the direction of force. It has two components, distalization and vertical component for intrusion. If you want only distalization, then you need to insert your microscope below the mucogingival junction. If by any chance you screwed your microscope above the mucogingival junction, but you need only distalization, you need to adjust your point of attachment of the force by adding hook to the wire, for example, and you adjust the length of the hook accordingly. So again, you need to consider the root morphology. Wider area present more vertically. So when you insert your microscope, you need to angulate your microscope more toward the apex of the root. It's preferable actually to insert microscopes in attached keratinized gingiva because attached gingiva provides more healthy tissue and less tissue mobility. When there's less mobility, there's less inflammation and so less failure. So if you have a patient, you want to insert a microscope for this patient, you need first to identify the insert point you need to identify the insert point by localizing where you want to place your microscope. You need to take periapical radiograph to the surgical guide, which is a piece of wire that can be attached to the teeth through a utility arch, or if you have fixed appliance already bonded, you can attach a piece of wire to the fixed appliance, then locate the insertion point, take periapical radiograph. The periapical radiograph has to be perpendicular for more accuracy, and then you locate the insertion point. You need not to interfere with the roots of the surrounding teeth, and you need to be away from the neurovascular element in the region. After that, you need to insert your microscope after localizing the insert point, either by self-tapping or self-drilling technique. If we are going to start with the self-tapping technique, there are two protocols for the self-tapping insertion. The first protocol without flap reflection. You need just to give a few drops of anesthesia in the gingiva and then just do soft tissue punch. Use handpiece to create a pilot hole, and then after that use a straight driver to screw your microscope without flap. The second protocol is with raising a surgical flap. So you need to give full local anesthesia. You reflect a flap and then you directly drill and create your pilot hole. You do the screwing and then you close the flap. The second technique is the self-drilling, which is I prefer it and I feel it is easier than the self-tapping technique. You just need to clean the mucosa with the chlorhexidine after you locate the insertion point. You can ask the patient to rinse with chlorhexidine, and sometimes you can use gauze soaked with chlorhexidine and clean the area. After that, you just screw your microscope directly into the bone. Of course, after giving few drops of anesthesia into the gingiva. You don't have to give full local anesthesia because you need the roots to be still sensitive. So if you are close to the root, the patient can shout and say it's painful. So you know your direction of insertion is wrong. You need to adjust it. The success rate for microscope has been reported to be between 50% to 90%. And they consider it successful when there is no source of inflammation, there's absence of clinically detectable mobility, and when the microscopes are capable of sustaining the function and the anchorage throughout the course of treatment. Park et al. In 2006 found a success rate around 92%, and they suggested that microscrews were more successful in the maxilla than in the mandible, more successful in the left side than the right, less successful with inflammation, and less successful when there is mobility. Why it's in the maxilla, not more in the mandible? I don't know, but maybe because of the type of the bone in the maxilla. In the mandible, the bone is denser. So maybe the chance of success is higher in the maxilla. Why it's more in the left side? I assume because the majority of patients are right-handed, and when they brush their teeth, they clean the left side maybe better than the right side. However, others rejected this. For example, Moon et al. In 2008, they suggested that gender, age, jaw, whether maxilla or mandible, soft tissue management, and placement site were not related to the success rate of mini-screws. Also, it's been suggested, and I think we all agree with this, placing microscrew in keratinized attached gingiva associated with higher success rate than placing the microscrew in non-keratinized or mobile tissue. Regarding the diameters and the length of the microscrew, again, can it affect the success rate? Yes. Usually, the diameter of microscrew has to be more than 1 millimeter. If it's less than 1 millimeter, it's been reported that it's associated with high risk of failure and high risk of fracture as well. But between 1.5 to 2.3, there's no difference. So you can choose your microscrew between 1.5 to 2.3 and or 1.2 sometime. Chris Mani et al. In 2010 suggested using 1.2 millimeter diameter and 8 millimeter length microscrews to provide the greatest success rate. What are the effects of mini-screws on the adjacent tissues? When we say adjacent tissues, we talk about the roots of the adjacent teeth, we talk about the alveolar bone, and we talk about the gingival tissues. So as long as your screw is away from the root, there is no effect on the pulp. The effect is negligible. Alveolar bone, we did a study in 2012, and we found that the mini-screws resulted in increase in the alveolar bone density after 3 months of insertion. The effect on the gingival tissue also were found negligible. Now, whether it's immediate loading or delayed loading, can we load our microscrews immediately? Yes, majority of the authors suggested to immediately load your microscrew, and they suggested that the orthodontic loading appears to have no influence on osseointegration, and early loss of the screw is not because of the immediate loading, but it's because of the lack of primary stability. Remember, we mentioned that primary stability is important. When you insert your microscrew, you need to check the stability if there is no mobility. But having said that, sometimes very minimal and light mobility is accepted, as you will see later. Whereas others recommended to wait for 2 or 3 weeks and sometimes up to 6 weeks before loading, maybe in order to achieve sort of osseointegration and to be safer. What are the complications of using microscrews? These can be complications during insertion, during force loading, or during removal of the microscrews. So during insertion, the main complication is lack of primary stability. If there's no stability, it means the microscrew will fail. So in this situation, you need to choose different location and relocate your microscrew. If you feel that your microscrew while you are inserting is getting into the periodontal ligament or touching the root, again, this is a complication. You need to remove your microscrew, relocate it into another area. Complications during the loading, force loading. The main problem when you load your force is getting mobility of the microscrew. So if the microscrew loosen, start to be mobile while you are loading your force, don't expect the stability will regain again. Again, you need to remove it, relocate it. Also, hypertrophy of the mucosa adjacent to mini-screw. When you attach your force system, for example, power chain or coil spring, okay, to the microscrew, there will be area of stagnation of plaque and fluid stagnation. If the patient oral hygiene is poor, then expect that there will be hypertrophy of the mucosa adjacent to meniscus. Remember, if you are inserting your microscope in attached keratinized gingiva, this risk is minimal. Complications at removal. Sometimes when you are trying to remove your microscope, you will find that the microscope resists the removal. In this situation, don't try to remove it at this appointment. Just leave it for a few days, according to Milson and Werner. Just leave it for a few days, and when you retry later after a few days, you will find that the screw will be removed easily. Fracture on removal. If you are trying to remove the screw and the screw fractured, then in this case you need surgery actually to remove the remaining part of the screw. I think I will skip this because we are late. I think we will skip this, the infrazygomatic crest screw. This is different type of microscrews. Those microscrews are inserted in alveolar bone. In this situation, the microscrew is inserted in the infrazygomatic crest, which is a bone emanating from the buccal plate of the alveolar process lateral to the roots of first and second maxillary molar. In young patients, it's located between second premolar and first molar, whereas in adult it is more posterior, located between first and second molar. Why infrazygomatic crest? Because it has denser bone. So it has denser bone and has two cortical plates. So the primary stability is high here. But in this situation, you need to use microscope made mainly of stainless steel, pure stainless steel. And it's longer than the microscope for the alveolar process. It comes either 12 or 14 millimeter in length. Diameter should be higher. It is minimal 2 millimeter. And of course with angulation. So when you insert your microscope, you need to redirect the microscope about 55 to 70 degrees inferior to the horizontal plane to achieve maximal buccal bone engagement. As I mentioned, the density is high. It is more than 1,250 Hounsfield unit. So you need stainless steel because it's a high fracture resistance to titanium alloy, 12, 14 millimeter in length and 2 millimeter diameter. You can load it immediately. Yes, of course, you can load it immediately because it provides higher primary stability because of the two cortical plates. You can load with higher force. Yes, higher force can be also tolerated by single screw. Around 300 to 350 grams can be used safely. So now let's talk about the study we did in Jordan University of Science and Technology about the alveolar bone density change around microscopes, from where we got our idea from the primary stability. As we mentioned, the mobility of microscope is considered a sign of failure. However, some authors, like Park et al., for example, suggested that slight mobility after insertion is not a sign of failure. He found that out of 45 microscopes with slight mobility, 34 were successful, which is a good percentage actually. So why after insertion there's slight mobility but high percentage of the screws were successful? What happened? We thought about doing studies, clinical study, to assess the alveolar bone density change around screw upon loading, and also to assess the gingival tissue changes. In a prospective clinical way, we recruited 22 patients with average age of 17 years and 8 months. We inserted overall 44 titanium screws, 2 per patient, between second premolar and first molar, maxillary first molar, of course, at the mucogingival junction or just below the mucogingival junction, in order to eliminate the effect of fixed appliance on the alveolar bone density. We need just the effect of microscopes, okay? So we need to choose a control area to be assessed also and compared to the study area. So we choose a control area between first premolar and second premolar. So remember, area between first molar and second premolar is the study area where you insert your microscope. And the control area, there's no microscope between first premolar and second premolar. Inclusion criteria included orthodontic patients older than 14 years, no history of orthodontic treatment, no extracted or missing teeth, no active periodontal diseases, of course with adequate oral hygiene, with average or increased overbite, because our plan was to distalize teeth, and with distalization you will reduce the bite, so we need from the beginning average or increased overbite. Medically and mentally fit patients, and the malocclusion has half unit class 2 molar relationship to be distalized, because our plan was without extraction and distalization on the microscope placed between second premolar and first molar. So we started with localizing the insert point by taking X-ray to the surgical guide. We localize the insertion and the starting point. It's 1 millimeter just below the mucogingival junction. Okay, and then we gave a few drops of anesthesia to the gingiva. We asked the patient to rinse with chlorhexidine, and we cleaned the area with chlorhexidine, and we started our insertion with self-drilling technique. Then we placed our microscope between second premolar and first molar. The screws we used were 1.3 millimeter in diameter and 8 millimeter in length. They were titanium from APSO-Anchor system, and of course self-drilling technique. They were inserted by one operator, which was myself, and inserted just below the mucogingival line. All patients had fixed orthodontic appliance, the same, standardized, 0.22-inch slot size, Roth prescription. We started our force application after 2 weeks of insertion with a force level of 200 grams. We made sure that the force is standardized by using force gauge to measure the force. The force was through applying elastic chain, power chain from the microscrew to the hook on the canine bracket in order to move the upper anteriors back. Then we assessed two parameters. We looked at the gingival clinical parameters, and we assessed the alveolar bone density from digital periapical radiograph. The gingival clinical parameters, we looked at the probing depth, gingival enlargement, width of attached gingiva, width of keratinized gingiva, lack or calculus around meniscus, redness or enlargement around meniscus, and of course we checked the vitality of the adjacent teeth, second premolars and first molars through using ethyl chloride. Alveolar bone density was assessed by using digital periapical radiograph and by using the GORA for Windows software. We assessed those for both the study area between first molar and second premolar, and for the control area between first premolar and second premolar at 4 time points, of course, before insertion, T0, 1 month after insertion, T1, and 3 months after insertion, and then 6 months after insertion. So for each patient, 4 sets of periapical radiograph will be taken for each side. So for each patient, you will end up with 8 digital periapical radiographs. Then we use the GORA software, and as you know, for alveolar bone density or for bone density, they usually use the subtraction technique to assess the density, to compare the before radiograph with after radiograph, and then to subtract this from this. But this requires very accurate technique, very accurate reproducibility. If by any chance you change the angulation or the reproducibility wasn't 100%, your measurement will be affected. So instead of that, we used another way, which is by using fields of view, by selecting 7 fields of view, 3 at each side and 1 apical to the microscope. Same for the control area also. The analyzing software measurements of bone density, it measures the bone density on a scale from 0 to 255 Hounsfield unit, where 0 represents the most black, which is less dense, and 255 represents the most white, the most dense. Okay. Again, it was assessed for both study and control area, and then we measured the mean density for each field of view. And then for the alveolar bone, we measured the mean for the 7 means of field of views. What we got a success rate of around 88.6%. Only 5 screws failed, and the failure took place mainly in the first month of insertion. The adjacent teeth were vital through the study duration. We found that at baseline data, before insertion of microscrews, males had denser alveolar bone than females. So looking at these two charts, the bone density increased significantly in the study area after 3 months of insertion. In the study area, between T0 and T1, the alveolar bone density reduced slightly, non-significantly. This is because of the crushing effect of the microscrew. When you insert your microscrew, there is a crushing effect to the adjacent alveolar bone. And then after the first month, it starts to increase the alveolar bone density, but again, non-significantly until the 3rd month, after which the density increased significantly until the end of the study duration, 6 months. Whereas in the control area between premolars, the alveolar bone density increased slightly, non-significantly. The difference between T0 and T2 was 0.02. And then it stayed stable after that until the duration of the study. What does that mean? It does mean that the fixed appliance, by looking at the control area, fixed appliance treatment or tooth movement has no effect on the alveolar bone density. Whereas the microscrew insertion and loading resulted in significant increase of alveolar bone density after 3 months of insertion and loading. Keratinized gingiva, the width of keratinized gingiva increased significantly during the first month for both, actually, for study area and for control area. This is expected because gingival inflammation is associated with fixed appliance treatment. Most of our patients have enlarged gum, especially if the oral hygiene is not perfect. So we found that the width of a keratinized gingiva increased significantly during the first month. After that, it increased, but non-significantly in both. Same behavior for both study area and control area. It means that the microscrew insertion or loading has nothing to do with the width of keratinized gingiva. So to conclude up with, we found that males have more alveolar bone density than females. We found that density increased significantly around microscrews after 3 months of insertion. There were no detrimental effects on the adjacent gingival tissues. The width of keratinized gingiva increased significantly 1 month after treatment as a result of fixed orthodontic appliances. And also we found that fixed orthodontic treatment did not affect the alveolar bone density significantly in the maxilla. Careful insertion, of course, will have no harmful effect on the vitality of the adjacent teeth. So based on the result of our study and based on another study actually, which was done by Melson et al. In 2015, and it was animal-based study in which they used 4 beagle dogs and they extracted premolar tooth, lower premolar teeth from each side. They used split mouth design. They inserted in one side extraction space microscrew and left the other side without microscrew. After 6 months, they followed them and they found that the microscrews preserved the alveolar bone. On the side they inserted microscrews, the alveolar bone level was higher than the side without microscrew. So microscrew preserved the alveolar bone. So also you can use microscrew in case, for example, of missing lateral incisor. And the treatment option is to have implant. But sometimes if our patients are young, you can't do implant until they are 18 years or 19 years and above. So meanwhile, during that time, you can use temporary temporary measures to restore the space by using microscrew, which in this situation serve as provide restoration for missing teeth. You can build the composite around it, and also it preserves the alveolar bone for later on implant placement. Because what's the common problem? Alveolar bone resorption. when you come to the patient when he is 18 or 19 years old, you will find that the alveolar bone has resorbed, and you will need to do alveolar bone graft in order to be able to insert your implant. So let's show some clinical cases with you, and let's start with intrusion of molar tooth. The molar is expected to over-erupt if the opposing molar extracted previously. So the molar will over-erupt, and in order to restore the lower molar, you need to intrude this molar. So the plan was to intrude it using microscopes. We inserted 2 microscopes, one mesial, one distal to the first molar to apply force, intrusion force. But remember, if you applied force from one direction, you will end up with the tooth flaring buccally. So in order to avoid this, we also inserted microscope from the palatal side, okay, to apply force simultaneously from palatal side and from buccal side. So we bonded attachment to the molar tube, to the molar tooth, first molar, and then we applied intrusion force from the buccal side, and button bonded to the palatal surface, and force applied to the microscope from palatal side in order to get intrusion. With time, you can notice that the situation is getting better. And from here to here, it took around 4 months to achieve good level of upper first molar. It's leveled now with the adjacent teeth, and the vertical clearance for the lower restoration is enough. Correction of maxillary arch canting. Sometimes patient comes to you with canted maxillary arch. So usually this is surgical case. You need to do maxillary surgery to cut wedge from one side and then impact it to correct the canting. But with the introduction of temporary anchorage devices, you can correct the canting with microscopes or with miniplates, if you remember. So here the plan was to intrude the canted side by using miniscrews. We inserted 2 miniscrews on the side of canting from the buccal side, and of course from the palatal side to overcome the buccal flaring. And we applied force, intrusion force, through using elastic chain from the archware to the microscrews. Again, with time, it takes time to notice that there is improvement. And from here to here, it took around 6 months of force application, but things getting better. Uprighting of posterior teeth. In this situation, the lower second molar is mesially tilted and trapped behind the lower first molar. So the plan was to upright it using microscope inserted into the retromolar area. Orthodontic button was bonded to the most distal part of the tooth, and a force was applied through elastic chain from microscope in the retromolar area to the orthodontic button. With time, it is improved. This is another situation where a previous extraction of lower first molar resulted in mesial tilting and space loss of the first molar space. So the plan, in order to put restoration here, the plan was to upright the tooth using microscope inserted in the retromolar area. And again, in this situation, we bonded orthodontic button on the mesial surface of the second molar. We applied force by using power chain from the microscope to the orthodontic button. But in this situation, the chain crossed the occlusal surface on purpose, for sure, because we don't want the lower second molar to extrude while we are uprighting it. So the elastic chain crossed the occlusal surface to limit the vertical position of this tooth. So here, the button bonded, microscope, force applied, the it's not clear because of the light. This is a power chain running from here to there, and eventually the space for the implant is more than enough. Class 2 Division 1 malocclusion. This is a Class 2 Division 1 case with increased overjet and prominent upper incisor. The plan was, if you look here intraorally, you will see there's severe crowding in the lower arch with one premolar outside the arch. But fortunately, the midlines were not that bad actually. Although one unit here is out of the arch, the midline wasn't shifted to this side. So the plan was to just take this lower first premolar, and of course from the upper arch taking two first premolars to retract and correct the proclination of the upper incisor and reduce the overjet. What I would like to mention here, if you look here, the decision was to take this first premolar and the upper first premolar. Remember, there's no space here to close, but there will be one unit space here to close. What's the molar relationship? It's class 1. So we can't afford that the upper molar move forward. We need to keep the class 1 molar relationship. On the other side, the molar relationship is for unit class 2. You will take one single unit from here, but nothing will be taken from the lower arch. Again, we can't allow upper molar to move forward. We need to keep the full unit class 2 molar relationship. So this case is described as high Anchorage demanding case. So the plan was to, after extraction, to insert microscrews in the upper arch between second premolar and first molar, then to apply force. Look at the direction of the force here. It has two components. Because of the deep bite, it has two components, vertical and distalization. Once we reached the stainless steel arch wire level, we inserted a stainless steel arch wire with bite opening curve. Okay, bite opening curve or curve of Spee, accentuated curve of Spee. This bite opening curve to help in overbite reduction, but as a result of bite opening curve, in placing bite opening curve, you would expect that the upper incisors will move forward. In order to prevent this, we applied force from the microscrew to a hook placed on the upper arch wire, okay, to start distalization and space closure, while the arch wire with bite opening curve start bite reduction. Again, here the space is closing, okay, on both sides, and the molar relationship is still class 2, class 1. The space is almost closed, but the overbite is still somewhat increased. So we decided to put two microscrews in the anterior region between the central incisor and lateral incisor and apply intrusion force to the upper labial segment. And from here to there, it took around 13 months. Now look, canine relationship is class 1, overjet reduced, bite reduced, molar relationship is full unit class 2. So you preserve the anchorage in a nice way here by using microscope. Bimaxillary proclination case. This is a bimaxillary proclination case. It's class 3 with reduced overbite. If you look at the lateral curve of the patient, upper and lower incisors both proclined, the bite is reduced, lower vertical dimension is increased, maxillary mandibular plane angle is increased. So this is high angle case. In high angle case, we expect to lose anchorage very easily. So in order to achieve proper retraction of the upper incisor and lower incisor, we decided to put microscrew in the maxilla. In the mandible, we are not usually afraid of anchorage loss because of the type of the bone. So we extracted, of course, 4 units, 2 fours in the upper arch and 2 fours in the lower arch, and we placed microscrews between first molar and second premolar, and we started a space closure. Look at the direction of force. It's almost parallel to the occlusal plane because we want only distalization. We don't want intrusion because the overbite is reduced already. So through the treatment, we started space closure in the upper arch by using coil spring from the microscrew to the hook, and in the lower arch using elastic chain. It's difficult to see it maybe, from the hook on the lower molar band to the hook on the arch wire, solder to the arch wire. The space is closing. This is the finishing stage where you finish your case, and eventually the molar relationship, class 1 canine, class 1 overjet is normal. The inclination, angulation of the upper incisors and lower incisors look normal. And this is the final at the bond stage, where when we also took our microscrews out. It took around 14 months to achieve this result. And if you look at the pre-treatment lateral cuff with the pre-finish lateral cuff, you can notice the amount of incisor retraction, upper and lower. You can see also the profile change. This is the tracing of the lateral cuff before and tracing of lateral cuff just before the bond. This is the red color after, the black color before. When we superimpose them together, you can see the tooth movement that took place during the treatment. The upper incisors retracted back, moved back, and the angulation changed. Lower incisors moved back and the angulation changed. This is the key point. Upper first molar didn't move forward because of the microscope. We couldn't allow for the upper molar to move forward because of the high Anchorage demand in this case. Whereas the lower molar was expected to move a little bit forward, and it was okay. Now, this online teaching is more effective than face-to-face learning. I hope so. I would like to thank you very much for your attention, and I'm happy to take any question you may wish to ask.
Thank you so much, Dr. Ahmad, for the fruitful presentation. So any questions, any comments?
I have a question. Thank you for your excellent presentation.
Thank you very much.
Your research, you mentioned several times changes in alveolar width, bone thickness. Density.
Not thickness.
Okay. Alveolar bone density with microscrews in the study and the control group.
Yeah.
Now, when you say significant difference, did you mean statistically significant difference or clinically relevant difference? What was the clinical relevance of that difference in density of the bone?
Well, clinically, you can't see anything clinically because it's alveolar bone. You can't see the alveolar bone. You can figure it out on the radiograph, although it's difficult to assess the density on the radiograph by eye. You need software. But if you remember, I showed the last slide in which we concluded that the microscope preserved alveolar bone. When the alveolar bone density increased, it is as a result of the reactionary force around the microscope, which means it helped to preserve the alveolar bone. This is important in case of missing tooth, for example, to be replaced later on by implant. You need to preserve alveolar bone. Okay, so later on you don't need to do alveolar bone grafting. You need to keep the alveolar bone. Sometimes we keep the primary teeth to preserve the alveolar bone. Okay, if the tooth is lost, inserting microscope can keep the alveolar bone for future implant placement.
But you mentioned the density. In terms of preservation of the bone, did you actually measure the bone volume and the height of the bone?
We measured the bone density, but it's all over, and it was supported by another study by Milson, as I mentioned, in 2015. Okay, they used animal study for Beagle's dog. They extracted the first premolar and they inserted on one side microscope. They left the other side without microscope. After a time, they checked. They found that the microscope preserved the alveolar bone volume and the height and the level compared to the other side.
And how did you clinically measure the area of the keratinized gingiva? In your
How clinically we measured it? It's the distance between the mucogingival line to the free gingival groove. This is the keratinized gingiva. Now if you remember, we measured two things. We measured keratinized gingiva and we measured attached gingiva. In the attached gingiva, it is the distance between the mucogingival line to the free gingival groove. Whereas the keratinized, adding to this the distance between the level of the gingiva to the free gingival groove. Why we did so? Because it's expected in all orthodontic patients that the gingiva will overgrow. It's very common for orthodontic patients to have hyperplasia in the gingiva. So we need to assess the effect of microscrew on the attached gingiva, not on the part associated with the tooth, which can be affected by the fixed appliance itself. Do you know what I mean? The attached gingiva and keratinized gingiva. Attached gingiva, that's attached to the bone. It is measured between the free gingival groove to the mucogingival line. Keratinized gingiva, in addition to this length, the length from free gingival groove to the gingival level. This, around the tooth, can be affected by the plaque, by the fixed appliance, which can result in hyperplasia of the gingiva.
and equally recession.
Usually we don't get recession actually in orthodontic patients. Most of the time they have hypertrophy because of the oral hygiene. It's very difficult to keep good level of oral hygiene. You're welcome.
Well, you talked about the headgear causing ocular injury, for example.
Yes.
What about mini screws or TADs? If they are there any case reports where they have come out and being inhaled or swallowed by patients?
No, never actually. Usually when the microscrew starts to loosen, the patient will feel it. So the patient will come immediately to the orthodontist. Okay, I never read actually any case report about inhalation or swallowing of losing microscrew. Yeah.
How do you understand that your mini screw is very close to the roots of the tooth? You mentioned reaction from the patient.
Yes.
Is it just the reaction of the patient or any other sign?
If while you are inserting your microscrew, you mean it's close to the root, yes, the patient will start to feel pain.
But if it is treated, root canal treated teeth?
Yeah, it can be. That's why, but this is not the common scenario. That's why we mentioned to give only a few drops of anesthesia to the gingiva, but not to anesthetize the tooth. We need the tooth to be awake. You know what I mean? Yeah. And of course, taking all the consideration to localize the start point, to localize the direction of your insertion from the X-ray, from the anatomy of the root, all these should be taken into consideration as well.
Maybe CBCT.
Is it justified? I don't know.
No.
I don't know.
CCCT for one screw.
Or intraosseous perforators. Maybe can we use intraosseous anesthesia perforators to, measure that area?
No, I think if you know the procedure, it's easy. It's easier than what you think about it.
The risk is not high.
Yeah.
I've been doing it since
Actually,
'98.
you will feel
It's
resistance.
fairly
Yes,
straightforward.
exactly. Yeah.
You will
That's
feel
why I
resistance.
mentioned you need to use
Yes,
your
that's
tactile sensation. I mentioned this in the lecture.
This is the endodontist point of view.
Yeah. You are caring about the roots. Yeah.
But I think since the TADs came, millions have been placed. There are very few reports of teeth
Yes.
becoming devitalized. Or
Yes.
you hardly ever read any bad report.
Yes, and also many reports came if you touch the root and you figure out that you touched the root and you remove the microscrew, the tooth will be not affected.
Because the nerve is going through the root apex, not through
Yes.
the middle third of the root or whatever.
Yeah,
So
yeah.
even if you touch the root, that doesn't necessarily mean that the tooth will
Yeah,
be
but
its right
it
direction.
might be get infected.
If you kept the screw,
secondary infection.
if you kept the screw But remember, if the screw goes in the periodontal ligament, it will be loose. And you will not achieve primary stability. So anyway, you remove it. Even if the patient didn't shout, oh, it's painful, it's going to be loose, okay? Because it's in a space, not in a cortical bone.
If it's touching the cementum, that doesn't necessarily per se increase the infection risk. Why? If it's in the bone and touching the cementum, so what?
But,
No, in the cementum, it can initiate
Resorption.
good resorption.
Yeah, that's the only problem.
But not infection, I mean.
Not infection.
Yeah, but
resorption.
resorption, still
Definitely
still a
different.
resorption, yes.
And that will be localized.
Even though it can affect the stability of the tooth in the future.
not from this mini screws, but I just.
It's a guesstimate and it's
I mean, I wanted.
subjective, you know.
Very rare.
Whether
It's
this
amazing how few reports there are about
Very-
any complications with tads.
Yeah. Very few actually.
they've been
It's very safe.
done for
Very safe.
decades now.
Thank you so much, Dr. Hemad,
You're
for
welcome.
the nice presentation, and
you.
you definitely added a lot to our knowledge. My question is regarding the mini screws themselves. Do they can cause any sort of trauma or injury, and especially regarding the palatal area?
You mean to the tongue?
Yeah.
Well, you can consider it as any part of fixed appliance. The bracket hook itself can cause irritation to the cheek, can cause irritation to the lip. Okay, that's why we usually gives our patient utility wax after bonding up. And remember, all patients can adapt to anything. So after a few days, the patient can adapt to the new situation. So this is not a problem at all.
Think of the trauma with, you know, potential compliance with headgear. This is much more convenient.
Dr. Arfad,
Yeah.
I have a question. Would you prefer yourself self-drilling or self-tapping? Can you hear me?
Yeah. Say that
what
again,
do you
sorry.
would you prefer yourself self-drilling or self-tapping technique to insert this micro screw?
Yeah, myself, I prefer self-drilling, to be honest. I feel it is easier and it's quicker than self-tapping. And I don't have to use handpiece to prepare pilot hole. I think self-drilling, for me, it's easier.
Okay.
But of course, both techniques are there and they are safe. As I mentioned in the lecture, many studies suggested using this or that, no difference.
And do you prescribe antibiotic after the insertion of this mini screw?
No, there's no need. There's no need.
No. Okay. Any question?
Absolutely no need. The criminal to prescribe antibiotic.
Regarding these temporary Anchorage devices, your session was definitely, it was a wonderful session. My question is regarding the placement of these temporary Anchorage devices. Do you think which angle of insertion provides the greatest stability? I mean, for all of these temporary Anchorage devices.
That's a good question, actually. When we insert our micro screw, we need to localize the insertion point, and then we need to angulate our micro screw more apically to a wider interapicular space, because it gives wide space between the roots, and also it provides more contact with the cortical plate.
Yes.
So with angle, it provides more contact with cortical plate, which means more primary stability and more success rate.
So do you think it should be all of these temporary Anchorage devices should be perpendicular to the cortical bone, or it should be more obliquely placed, or oblique angulation is preferable for the more contact with the cortical bone?
Yeah, as I mentioned, obliquely or with angle is preferable because it gives you more contact with the cortical plate. Also, it's away or it moves toward wider area between the root, so more safety. Okay, but having said that, sometimes you have to insert it in a perpendicular direction. Now, what's the difference? The difference is the amount of the contact with the cortical plate. Do we need that much amount of contact between cortical plate and micro screws? Of course, the larger amount, the better stability. But that doesn't mean if you achieve some sort of contact, it will not be stable. You know what I mean? Preferably with ang, if this is the answer you are looking for.
Thank you.
You're welcome.
Dr. Ahmad,
Yeah.
just maybe the last question. You have mentioned in your study that males are more, have more bone density than females. Can you please elaborate more about that?
Yeah, we found that males have more density than females, and actually this is not mainly our finding. It's also finding of other previous studies. They found that males have denser bone than females, whether it's general bone or alveolar bone. This may be related to the fact that males generally have larger bone volume than females, have larger cortical plate than females, also may be related to the hormonal characteristics and hormonal changes associated with females. We explained this in our study in this way, and I also remember that it's been explained before by the previous studies that it is related to the thickness of the cortical bone. It is larger in males compared to females.
Thank you so much.
You're
Any
welcome.
question? Any comment?
Excellent presentation.
Thank you very much. Thank you.
Thank you, Dr. Ahmad, and for all the attendees. And please submit your feedback to get the certificate. Thank you so much. See you again in another seminar series. Bye bye.